Hello and greetings. This is Dr. Vijay Bose from the Asian Orthopedic Institute in Chennai. There seems to be a lot of confusion regarding alignment concept in TKR, especially amongst the less experienced surgeons. So this presentation is to simplify and also unify alignment concept TKR so that eventually patients can benefit. This presentation comes in two parts. The first part is titled as the pocket abridged CPAK. These days, in all arthroplasty conferences, it's very interesting and fascinating to see a lot of debates with surgeons debating each other as to which is the best alignment. And there are a lot of new alignments coming up as well. So obviously, there's a lot of confusion. Now, remember that there's always a price to pay for confusion and lack of clarity in anything in life. And these days, now we are seeing this crop of early failures following TKR. We never used to see this earlier, and now we are seeing those. Now, remember that we have to be very careful about this. Now, currently, TKR is considered to be the third most impactful surgery on the population in any part of the world, third most, including the whole of the world of medicine. It has just displaced coronary artery bypass grafting as the third most impactful procedure. So TKR is such a fantastic procedure, giving such fantastic results, and we must be careful that we must not spoil the reputation of TKR in the population. I think that's very important. The question to ask is that is personalization justified? John Insull described the mechanical axis in 1985, and this is an example of a systematic alignment. As we know, Stephen Howell described the kinematic alignment in 2007, and this is an example of a fully personalized approach. Now, those surgeons who believe in mechanical alignment tell us that kinematic alignment is not safe for many patients. In contrast, those who believe in kinematic alignment tell us that if we follow mechanical alignment in all patients, many of the patients are unhappy with the TKR procedure. So this is basically the divide between the two. Now, to understand the implication of systematic and the personalized approach, I think this is a good example. Now, suppose if you are organizing a reunion of your classmates from school and you don't know the t-shirt sizes of everyone, it's probably one way to overcome the problem would be to order the median size of t-shirts for everyone. This will be an okay approach, but obviously it will not be great. And this is what we do when it comes to situations in which there's bone and ligament damage and we don't know how it was before the pathology set in. And like when we do any hinge or revision knee, we put the standard only one alignment every patient. Now, this is the only thing that we can do because we have no idea how it was before the pathology set in. However, if you know what is the pre-orthotic alignment, then just common sense that it would be a better fit and a better outcomes if we're able to customize it for that particular patient and we can individualize patient specific factors. Now, therefore, personalization is certainly justified. I don't think there's any question about that. Now, personalization in arthroplasty is not new at all. We had personalization in shoulder replacements for a long time. All the shoulder components are modular in nature, and we can change based on the neck shaft angle and many other parameters, offset, etc., and create whatever is the personalized anatomy for that particular patient. It's also not new in total hip replacement, where modularity, of course, not a good idea. So we have different prosthetists, which are monoblock. And then depending on the neck shaft angle, we tend to choose whichever neck shaft angle suits that patient. And that we believe now is a very important concept in balancing the THR. Now in TKR, the personalization is very delayed compared to the other shoulder and the hip. That's because of the stranglehold that John Insull's concept of having a neutral alignment in all patients was having in the orthopedic and the arthroplastic community. So people said this is the only way to do it, and you must not deviate away from that. So the John Insull's mechanical alignment had a stranglehold on TKR. Now, we must thank these two surgeons, Seb Parrott and Mark Pegnano, for actually proving that John Insull's neutral mechanical alignment does not hold true. So this is the landmark paper which convinced the world that actually one need not be neutral in all patients. So this was the first paper published in 2010 where 15-year survival showed no difference between patients who had neutral mechanical alignment and those who had a slight deviation. And this was a follow-up paper which published in 2018, which had the 20-year results of the same cohort of patients, showing there is no difference between the survival rates of those who are neutral alignment and those who have slight deviation. So there's absolutely no doubt that today that we have some freedom to deviate from the strict neutral mechanical alignment. Now, once the stage was set between the two ends of the spectrum, it's only a matter of time before people thought about combining both safety and personalization. And therefore, a lot of new alignments, which were basically hybrid alignments combining these two concepts, came up. Now, we have to acknowledge the original work of all these thinkers. Hungerford came up with the anatomical alignment, Johann Bellemans with the constitutional alignment, Hummel described the adjusted mechanical axis, Benitoli described the restricted kinematic alignment, and Wincogde-Grave described the inverse KA alignment. Now, these days we find lots of new alignments coming up with variations of these, and therefore there's a lot of confusion, especially with the less experienced surgeons, as to which way to adopt. And obviously, all these original thinkers tell us that their way of alignment is the best, and therefore a lot of confusion. Now, as we have seen earlier, there's always a price to pay for confusion, and we are starting to see these early failures. And we have to be extremely thankful to these two visionary surgeons who have cleared a lot of the confusion, and they have explained so many things regarding alignment in TKR. The Sam McDessie from Sydney, Australia described the CPAK matrix in 2021 in his landmark paper. Now, CPAK is the common language of knee alignment. Earlier, we were all talking different things. We were comparing apples to oranges, and there was no uniformity in what we were telling. What are we looking at pre-op and what we are trying to achieve post-op. However, after CPAK, we exactly know what was there pre-op and what we are going to try and achieve post-op. So that has really explained all the essence of what we're trying to do with these different alignment philosophies. Faris had described the functional alignment in 2020. Although it was described as an alignment, it's much more than an alignment. It's actually a philosophy. And many authors have expanded on this. The most significant work probably comes from Seb Lustig, and therefore it's now a functional alignment philosophy, not just an isolated alignment. And there are a lot of things that we're trying to achieve. This functional alignment philosophy is actually the core essence of all hybrid alignments. So the commonality between all the hybrid alignments, what it's trying to achieve, is encapsulated in the FA philosophy. So it's not just an alignment, but it's more of a philosophy. So now we have a common distal core philosophy of hybrid alignment, which is the FA philosophy. We now also have a common language and nomenclature of hybrid alignment, which is the CPAK matrix or nomenclature. So if you look at the FA philosophy, as we said, it is the core essence of all hybrid alignments, what the hybrid alignments are trying to achieve. It combines three important biomechanical principles or dimensions when you want to optimize your TKR. Now, the three dimensions are you want to reproduce some native morphology, alignment is important, balance. So all these three biomechanical principles are very important when you want to optimize the TKR. So if we give importance or give predominant importance only to the alignment, then we call it as mechanical alignment. If we give importance predominantly only to the native morphology, we call it kinematic alignment. If we give the predominant importance only to balance, then it will come under the gap balancing technique popularized by Buchel Papas. However, if you want to give equal importance to all of these three principles, then it will become the functional alignment philosophy. So that is the essence or the core of all hybrid alignments. Now, Hiranaka has described a lot on that. And in his classic paper, he describes how all these biomechanical principles come together in the functional alignment principle. So that is the core principles of the FA philosophy. We will expand on this a little later. It's very important for all of us to understand the importance and the relevance of CPAK today. 21 is a landmark paper by McDessie and colleagues. Describe these 9 phenotypes based on 2 factors only, the joint line obliquity and the arithmetic hip knee ankle axis. Now, any knee, any arthritic knee, normal knee or an arthritic knee can be boxed into one of these 9 boxes. And that is the important. So we know what phenotype they belong to based on the classification. So any knee can be put into one of these 9 boxes. And that's very important for us to understand. Now we have to have a long leg film if it's an arthritic knee, and then we calculate the LDFA and the MPTA, and based on these 2 parameters, we are able to put any knee into one of these 9 boxes. Now we must keep in mind that in a varus knee, only 6 boxes will come into the varus, and only if you include the valgus knees also, you have 9 boxes. So this presentation is going to be only on the varus knee. So we're only talking about the 6 boxes. Now, the joint line obliquity and the HK axis are actually 2 sides of the same coin. It's a bit naive to talk about one without the other. So these two, JLO and HK, are really 2 sides of the same coin. And for us to understand knee fully, we must include both. I think that's a fundamental requirement. Now, this is a great way of looking at the knees. However, there are two problems. One is that inexperienced surgeons find the CPAK classification to be daunting, taking these long leg films and calculating the angles and putting them in. More importantly, how to put this into practice in the day-to-day TKR, that seems to be a problem. And the second problem that we have is measurements in long leg films may not be very accurate because if there's a rotational element and we're doing a long leg film, then there could be potential inaccuracy. So these are the two problems that we have currently today with the implementation of the CPAK concept. It's always a good idea to stratify normal variations in any kind of arthroplasty. When it comes to the proximal femur, we're all very happy and delighted to stratify proximal femur. However, when it comes to the distal femur, we are still very reluctant and apprehensive because we don't have a good understanding of the distal femur. When it comes to proximal femur, of course, we can measure the neck shaft angle and classify them as baroid or median on valgoid. But most of them have this mental algorithm in our minds. And simply we tend to draw a line, horizontal line from the great trochanter, and then we classify femur as if the center falls below the line, we call them as varoid. If it falls at that level, we call it as median or standard. If it falls above, we call it valgoid. Now, it's very important that we get that so that uh, it's always better to stratify before quantifying. So we can do all the angles, but it's always better to stratify before quantifying. And then we put it into practice. We can choose whichever implant that matches your neck shaft angle. We can choose that particular implant for that patient. So we're all very happy and very happy to do this in the proximal femur. When it comes to distal femur, we are reluctant and apprehensive. And what if we have a method, just like we have for the proximal femur, that if you have a mental algorithm, then it becomes very easy for that. So the whole idea of the pocket abridged CPAK that we have developed is to simplify the distal femur, just like how we all have this mental algorithm and we can really simplify the proximal femur morphology. This pocket abridged CPAK is to simplify the distal femoral morphology. Now, how does this pocket abridged CPAK work? Now, if you have a long leg film like that, then obviously the thing to put it into one of the CPAK 9 boxes, we need to draw the MPTA and the LDFA, and then based on the joint line obliquity and the HK axis, we can put them into one of the 9 boxes. However, you must remember that this arithmetic calculation of MPT and LDFA angles required only if the medial and the lateral joint spaces are unequal in the knee joint. If you have an example like this, there's obviously varus of this limb. There's varus both in the femur and the tibia. But we find that the medial and the lateral joint space are equal. Therefore, there's no need to calculate any angle, NPT or LDFA to box this knee. So just by looking at that film, we know that it is neutral. There's no need to calculate any angle because the joint spaces are equal on the medial and the lateral side. Now, if you take a post-op X-ray, for example, after any TKR, correctly done TKR, and then you find that joint spaces are always equal, and I find the residents and fellows trying to calculate angles in this. There's absolutely no need to calculate any angle. You just draw the joint line, and we know that the apex is distal. There's no need to calculate any angle here. Now, what about this one, the bread and butter that we see every day, a standard osteoarthritic knee. So what do we do for that? Then obviously we need to get a long leg film and calculate the MPT and the LDFA to put it in the appropriate CPAK box. But that is in the pocket abridged version. What we do is we get a valgus stress film. Now, in the valgus stress film of the same patient I've shown here, now you find that the medial and the lateral joint space have become equal now, and therefore there's no need to calculate any angle at all. All that you have to do in this osteoarthritic knee is to draw the joint line, and then immediately we know that the apex is distal. There's no need to calculate. So if you do the valgus stress film, there's no need to calculate any angle. Immediately you know whether the joint line apex is either proximal or distal or neutral. And that's where the the pocket abridged CPAK comes in. So as we said earlier, it's always better to broadly stratify before quantifying. It's very important for all of us knee replacement surgeons to understand CPAK and knee deformity rules. And here's an example shown. At the most left extreme, you have a patient pre-op X-rays, long leg films, and you can see there's a lot of varus both in the femur as well as in the tibia. Now, because the joint lines are parallel, we can straight away draw the joint line, and we now know that it's a neutral joint line. The apex is neutral. Now, if we in this patient, if we do a correction of this varus by correcting the entire deformity in the tibia to get a neutral mechanical axis, you can now see how the joint line has been shifted into an apex proximal variety. You can see that. Now, the converse is also true. In the next film, if you find that you have corrected the entire deformity on the femur, then you'll find that you have changed this joint line apex into a distal joint line apex. You can see that very clearly in this illustration. And the only way that you can maintain this joint line neutral as in the pre-op condition would be to address the deformity both in the femur and the tibia, as shown in this planning long leg film. And then you can see that if you correct both the deformity, then the joint line tends to be neutral. And that's what has been done during the surgery for this patient. So this is nothing new and it's been well described in osteotomy literature. So to summarize this, if you find that the apex is distal, it indicates that more varus is coming from the tibia. If you have apex that is neutral, that means, and there's still varus, that means equal amount of varus is coming both from the femur as well as the tibia. And if we have an apex that is pointing proximally, then you find that the more varus is coming from the femur. So this is the final way of how we look at knee deformity. This is the final summary of how we look at the knee deformities. That's exactly what Johan Bellemans has done. And based on the 9 CPAK classifications, he has described very extensively as to how we can achieve the same CPAK post-operatively by factoring in all the LDFA and the MPTA in all our patients. However, as said earlier, there are two problems. Lex experience finds this process to be daunting, although of course very accurate. And the calculation of angles in long leg films, there may be some discrepancy, especially when there are some rotational issues involved. Therefore, with this pocket CPAK, we do not calculate any angles, and therefore we tend to overcome these two shortcomings. Now, it would be very useful if you could identify the 3 common types of distal femoral morphologies, just like how we are very used to the 3 types of proximal femoral morphologies. And for this, we need the valgus stress film, and this is the basis of the pocket abridged CPAK. Now, these are the 3 basic types of distal femoral morphologies that are shown in this picture. So the first one is we have in the valgus stress film, that's a significant distal obliquity, which is either 3 degrees or more. So that's the first type of morphology. The second type of morphology is that is still distal joint line orientation. The apex is still distal, but the obliquity is less than 3 degrees. The third type of one is one in which the joint line is neutral. So once we are able to identify or stratify all varus knees into these 3 types, then we are able to recognize these 3 types very simply, just like the proximal femur. The first one with the significant distal obliquity of more than 3 or more is the valgoid distal femur. The one that has got mild distal obliquity less than 3 degrees would be the median or the standard distal femur. And then one with a neutral joint line would be the varoid distal femur. So now we have exact equivalence of what we have in the proximal femur. And now this becomes very easy and straightforward to understand this concept and implement them in our surgery. So this is as easy and straightforward as the proximal femur. Now, how does the CPAK work within the CPAK matrix? So the CPAK matrix, of course, we have to calculate the LDFA and the MPTA. But here we work without calculating of these angles. So if we have one of this type that we said was a valgoid distal femur, that means that significant distal obliquity of greater than 3 or more, this would correspond to a CPAK 2. And if we have a mild distal obliquity of less than 3 degrees, or the median or the standard distal femur, this would correspond to a CPAK 1. If you have a neutral joint line obliquity, it would correspond to a varoid distal femur. And within the CPAK matrix, it could either be CPAK 4 or 5. Now, distinguish between 4 and 5, we need to have the long leg films. And this, if we find if both MPTA and LDFA is 90, it becomes a CPAK 5. If both are in varus, then it becomes a CPAK 4. So very, very straightforward. Now, the rest of the ones are very rare when they have either, as we can call it, a reverse joint line obliquity with the apex pointing proximally. It's very rare. And if we have like that, the valgus proximal, that means that the tibia is in valgus. So the proximal tibia is in valgus. So this will correspond to is 7 and 8 of the CPAK matrix, which are extremely, extremely rare. So remember, it's always better to broadly have a mental algorithm in your mind and broadly stratify before you start quantifying, so that you don't make any errors if you're able to broadly stratify. So how does the pocket abridged CPAK apply for TKR? So here is a classical patient with the OA of the knee. There's a long leg film. And when we use the pocket CPAK, we have to take the valgus stress film. And you can see that, and you can see the joint space have now become equal. And if we draw the joint line, you can see that obviously the apex is distal and it's more than 3 degrees. So it automatically becomes a CPAK type 2. We have found out it's CPAK 2 without doing any measurement of any angles. Now the post-op film, and you can see that the apex is facing slightly proximally. So what was essentially a type 2 CPAK pre-op has now become a CPAK 7 post-op, and this is what we want to avoid in TKR these days. So with the pocket CPAK, we are quite readily we're able to understand what's going on. Now, maintaining joint line obliquity optimizes outcomes in TKR. This has been well documented, a lot of papers in literature on that. The most important work has probably come from Dermot Colopy, and then a fantastic paper say how it's important for us to maintain the CPAK type pre and post surgery. Now, in conclusion, I'd like to say that just like how we have a mental algorithm in our minds for the proximal femur, makes it very easy to understand and implement variations in anatomy in the proximal femur when you're doing THR. I think it's equally easy to understand if you apply the pocket CPAK as regards the distal femur as well. And we are easily able to classify the proximal femur into 3 types. And we are able to get good functional outcomes by factoring in patient-specific factors when you're doing THR. And similarly, with the help of a pocket CPAK, you can classify into 3 types, the distal femur. And most importantly, we are able to implement during surgery and are able to exactly maintain the CPAK post-surgery what it was prior to surgery. I'd like to thank you for listening to this presentation. I'd like to leave you with the first slide of the next presentation. So this is the next presentation. This in the series of simplifying and unifying alignment concept of TKR. The next talk would be on achieving functional alignment and retaining CPAK type with and without robotics. So we can achieve this goal of what we're achieving, that is having a functional alignment philosophy as well as retaining the CPAK type both with robotics and without robotics. And the next talk will explain how to achieve that. Thank you again.